Hello, ladies and gentlemen, and thank you for joining us for another webinar from the Brain Aneurysm Foundation. Our guest tonight is Kim Lombardo from Northwell Health from Manhasset, New York. She is a nurse practitioner working with patients who suffer from brain aneurysms and subarachnoid hemorrhage, and more specifically, she worked with them after surgery and during their long-term rehab. She will emphasize the details that are important for the caretakers about the recovery from subarachnoid hemorrhage and both microsurgical and endovascular treatment of brain aneurysms. After the session is over, she's going to answer all the questions within the chat function, and this recording will be available within a few days from tonight. Kim, many thanks for joining us, and please go ahead.
Thank you, Dr. Cohen. Thank you very much for the Brain Aneurysm Foundation for having me tonight. It's my pleasure, and welcome everybody to this event. As Dr. Aaron Cohen said, I am a nurse practitioner from Long Island, New York. I work in a very large, healthcare system named Northwell. There are multiple sites. Manhasset is the largest cerebral vascular aneurysm center here on Long Island. I work with experts in the field. Unfortunately, tonight, Nicole Salant, who's my partner in crime, my colleague, had some events that were really, unpredictable, and she cannot be here tonight. But she is with us, in our spirit. I would like to take the first part of this lecture just to discuss a little bit about brain aneurysms, and because there are multiple ways to treat the aneurysm, it's important really to understand some of the concepts behind aneurysms and some of the risk factors involved. And then I'm going to get into patient recovery. So I think everybody knows really what a brain aneurysm is. It is a bubble off of a vessel wall. Why they form and how they form and when they form really is an unknown factor. There is really no screening today that's put out by the American Medical Association guidelines to really find out if you have a brain aneurysm. A lot of times they are found by accident or they're found through this rupture. And tonight we'll go through all of that. There are many types of different shapes and forms of aneurysms. As you can see right on my slide here, these are the three most common. There's a fusiform and a berry and a saccular. And these three types of aneurysms have all different shapes. They have different necks, and they're all on different vessels of the brain in the head and neck region. Fusiforms can be a little challenging to treat just because of the anatomy and the shape of the aneurysm and how it comes off of the vessel wall. And berry aneurysms have long necks a lot of times, and saccular usually are rounded. They have a big dome, some of them, and they have shorter necks. Some of the risk factors, are listed here. Many of these risk factors are listed, but the ones that are primarily focused on today is high blood pressure and smoking. They know the most about these two risk factors when it comes to brain aneurysms, and they do know there are some literature and some studies out there that smoking actually can cause these brain aneurysms to rupture. So smoking is one of the worst, kind of risk factor that you can have if you do have a brain aneurysm. You're very foolish to continue smoking because they do know that the chemicals in the nicotine can actually put stress on that vessel wall, and it can cause it to rupture. There are many ways to quit smoking today, so I do encourage anybody out there to look for options. High blood pressure can be silent, and it's something that you should really be following with a medical doctor, checking your levels periodically, at least once a year, to make sure that your pressure is under control. And that also can cause some pressure in the vascular system of the head and neck and can cause some problems with aneurysms. Oral contraceptives are also a concern, and these inherited disorders can be also associated with aneurysms and their ruptures. Family history is a very big topic. It's very controversial, and many patients ask, should their family get screened, especially children, siblings? It's a very common question today. I do encourage you to ask your physician what what their recommendation is today. But I know in our organization, if there are 2 or more family members that have brain aneurysms, then more likely they're going to screen the rest of your family members for brain aneurysms. Okay. Signs and symptoms of brain aneurysm rupture can be found right on the brain aneurysm website. It's such a wonderful, rich resource for aneurysm material. But these really are the most common symptoms if a brain aneurysm is ruptured. And many patients will tell you it was the worst headache of their life. It comes on very, very suddenly. I can tell you from listening to the stories of all of my patients that usually they're just doing something in the normal routine, in their normal activity, and all of a sudden they have this incredible severe headache that is uncontrollable pain, and some patients even fall to the ground. They can pass out, they vomit, they can have neck stiffness, they can't speak, their pupils look funny, their eyelid closes, they can't walk, they have weakness on one side. It really is very similar to an acute stroke presentation. And when you do have these symptoms that come on very suddenly, it's really very important to call 911 just to get to the closest hospital. These are really emergent critical red flag signs that you should know. If you know you have an aneurysm, you should know these signs and call 911 for any of these concerns. You can never really, go wrong once you get to the emergency department. They will do the correct testing to see if there is any bleeding and any concern. So I do encourage patients to know these signs and to call 911. Once you get to the ED, an emergency department, or any type of medical facility, how do they detect a brain aneurysm? There's a variety of images that they can do. The first one that they will do really is the gold standard, is something called a CT scan. And the CT scan really shows if there's any blood in the brain. And usually in a ruptured aneurysm, it's called a subarachnoid hemorrhage. That's really, a very common finding on a CAT scan if you do have a ruptured aneurysm. And as you can see right here where my marker is on this image is the white spaces that should not be there. They should not be filled in white. They should be filled in like this other gray matter. And that really indicates subarachnoid hemorrhage. Experts in the field will be reading this and they can pick this up. And it's, one of the most important tests that they can do. They also do in the EDs today something called a CTA. The reason they can do this test is because it takes 10 minutes. It's a very quick, efficient test. It really maps out the blood vessels of the brain, and it can see if there are any abnormalities along the vessel walls that could have caused this worst headache of your life, or cause some of the bleeding that's on the CAT scan that they see. This is a picture of a CTA when they do them in the ED or even in, any type of radiology facility, just to show you what a CT looks like. It's really just like a mapping out of these vessels here. This artery is called the basilar artery. You have 2 vessels in the front of your head and 2 vessels in the back of your head where all of the blood vessels really branch out from. And this one happens to be in a very eloquent area of your brain. It's in the middle of your brain, in the back, and many vessels branch off of it. But as you can see right here, there is a little bubble on the top of that basilar artery, and that is an aneurysm. So that's a basilar artery aneurysm that was found on the CTA of the head, and that's something that they can tell in the emergency department or in any type of facility when they do these images. And they won't see blood on this, but they will see the blood on the CAT scan. So many of these diagnostic tests, are very important to do in sequential events. An MRA is very important too. That's usually not done in the emergency room, but it can be done later on if they do see blood and a subarachnoid hemorrhage. And it really is a 3D view of the blood vessels. Here, this photo is actually an angiography photo of an ophthalmic aneurysm. So aneurysms really can occur anywhere in the brain on any of those vessels. The ophthalmic artery really is behind the eye, and you know, you could see this little bulge right here is an ophthalmic artery aneurysm, and they can see that on angiography. Angiography is done in an interventional room suite. And they do that invasively. It is not first line. They'll usually do a CAT scan. Sometimes they'll do a CTA, and then they'll do the angiogram. Angiograms really are a wonderful diagnostic tool that maps out all of the blood vessels of the head and neck. And I actually tell patients it's a lot like Google Maps when they do the angiogram, because it shows you every detail that you can imagine off of these vessel walls throughout your entire cerebrovascular system. It's kind of like looking at a house on Google Maps and seeing the mailbox and the number of your home once they do the angiogram. So it really is one of the best visual tests that they can do to look at any type of aneurysm or any concern that they have about a vascular abnormality that they see on the prior images. It does require, you know, a puncture site in your groin, the angiography, and it also requires some contrast dye, so there is some prepping that they do before they do the angiogram. Any skilled facility would know how to move forward and take care of that. This slide really goes over some of the elements that makes decisions decide how and when they're going to treat patients. So 3 elements that physicians really discuss and look at is the location, the size, and the shape of the aneurysm. Those are very critical elements that they look at to determine how you're going to be treated, because there are a few ways you can get treated. Along with those 3 elements, they also want to know if you've had a hemorrhage. Hemorrhage really is a critical event. You will be admitted for that. And if you're not in the right facility that can take care of, you know, vascular anomalies in the head and neck, they will transfer you to a place that can. So there are, you know, multiple places throughout the nation, even international, that are comprehensive stroke centers and brain aneurysm centers that will treat, you know, these type of abnormalities. And you would be transferred if they could not do any of the available resources in the facility you're in. Here we actually have, you know, Sky Health, which, you know, gets patients, you know, immediately here in a matter of minutes. Physicians and neurosurgeons is really a multi-collaborative team, multidisciplinary team that really get together to decide how they're going to treat patients once they are diagnosed with a hemorrhage and a ruptured brain aneurysm. They look at the patient's condition. They look at the patient's age. They also look at all of their medical history. They also look at medications. And they also, you know, get to determine which way they're going to treat a patient. This is a great photo because it shows the endovascular route, which is this little bubble, and it also shows the craniotomy route, which is this little bubble. Okay, and those are really the 2 approaches to treat brain aneurysms. Okay, now what about following someone conservatively, right? So that can be done too. The way they follow patients conservatively is if the aneurysm is found by accident or incidentally. And the way that's found is that patient's main complaint really is a headache or some type of neurological condition that they show up in a medical office for, and they decide to do an MRA. Once the MRA is done and it shows the aneurysm, you'll go to a specialist, and they'll decide if you need to be treated by these 2 routes or you're going to be followed conservatively. Smaller aneurysms usually get followed conservatively. And like I said, you're going to go back to my other slide, and they're going to look at these three things and really make a good, solid clinical decision on how to handle the aneurysm at hand. Okay. Hey, this first approach is a surgical approach. It's called microsurgical clipping. It's done by a craniotomy. Neurosurgeons do this type of treatment, and that's one treatment modality that the team can decide to do. And the craniotomy is done, as you can see right here, through an opening through the skull, and then they put a microscope right through the brain, and they go to the site of the aneurysm, and they put a clip right at the base of the aneurysm, as you can see right here. These clips actually look like little Barbie scissors, like Barbie doll scissors. They're very, very tiny. They're put on by neurosurgeons who are very skilled in the area, and they actually cut off the blood supply into that aneurysm. So that's what the clip does. They are very compatible today with MRI, MRA. So once they get placed into the brain, then you can go under imaging. You should always ask your surgeon, though, if it is MRI, MRA compatible, because some of the older clips are not. So it's important really to always ask your doctor about the compatibility. Once the clip is on, one of the goals is to stop the blood from going up into that sac to cause the rupture, or if it is rupturing, it will completely stop the rupture and prevent more brain injury. So that's the goal if you are, suffering from a bleed. And the other goal is to avoid any type of obstruction from the surrounding vessels that come off of that aneurysm, off of the vessel wall. So it's very important to preserve the blood flow around the aneurysm so that you don't suffer other neurological deficits as well. And that's called microsurgical clipping, and they just basically cut off the blood supply to the aneurysm. This is the second mode of treatment, a modality of treatment. It's called endovascular embolization. Many neurosurgeons are trained to do a combination of this and the craniotomy, and there are also neurointerventionalists that strictly do the endovascular embolization. This is done in interventional room radiology suites. It's a procedure, and there is no major incision, which really plays a lot into the recovery phase, which we're going to get into in a few minutes. But the embolization really is where they do the angiogram, and they go into the groin with a microcatheter. They put you to sleep, and they put the microcatheter into an artery in the groin called the femoral artery up into the aorta, which is the big vessel in your body, and then they go into the arch, which is right up here by your chest, and then they can put microcatheters all the way up into the brain that go and circulate into all of the vessels of the head and neck. And they find the aneurysm, they take a lot of images of the aneurysm, and then they can determine, how they're going to treat it with the stent and coil once they do the mapping out with the angiogram. If you are bleeding, they can actually do this and coil the aneurysm. Many patients out there have coiling of the aneurysm, and this is exactly what it looks like. This is a cartoon-like photo. But it's really one of the best visual photos that you can see from a stent and coil. So the expert will bring the catheter through the vessel wall right to the site of that aneurysm. They inject coils into the sac of the aneurysm. And then once that's done, they can at times put a stent there, usually not at the time of the bleed because the stent needs some Plavix and aspirin on board to prevent any type of embolic events, which are clotting. So a lot of times they'll put the stent in later on after the hemorrhage, usually within 30 days after the hemorrhage or even far out after 30 days. But this is a great photo of what a coil looks like. The coils are to prevent the blood from going back up into that aneurysm sac and causing more bleeding into the brain. So the coils stabilize the aneurysm that's ruptured, and they prevent further bleeding. Okay. Stents are put in for a number of reasons. Like I said, they're not going to be put in the acute phase, usually, days, months later. And the stent actually helps a few things. It helps the blood flow from one end to the other without going back up into the aneurysm for re-rupture. And it also helps the coils to stay in place, and it acts like a bridge. So the stent and coil really works hand in hand. It's a much easier recovery because it goes through the groin as opposed to the incision in the skull. And like I was saying, one of the side effects is that you have to go on Plavix and aspirin with the stent. You could have some, extra bleeding with that, but you are monitored very closely by the ordering physician. Okay, so let's talk about recovery. Recovery, really encompasses many symptoms here. As you can see, fatigue is one of the biggest symptoms. It is the most disabling and critical symptom that patients can really, have to overcome after the aneurysm rupture, or even if they do endovascular route. Fatigue is the number one most common disabling, debilitating symptom. Memory loss is very common. Many patients discuss memory loss as forgetting objects, or they don't remember, the event of the bleed at all. Very common. Or they can't remember, names of people, or even, events when they were a child. Short-term, long-term memory events, it's very common. Headaches are very common. Even if you never had a headache before, I have met many patients that get headaches even after, treatment of the aneurysm. Whether it was ruptured, whether it was found by accident, whether they had a craniotomy or they had the stent and coil, headaches, are very common. Surgical site issues I'm going to get into. The craniotomy has the skull incision, which can give you a variety of different things to look for. And the surgical site for endovascular is really the groin site. Okay, I have some photos as we move along to discuss that. Depression, anxiety is also very common. They do feel, a lot of patients fear that they're going to re-rupture again. And it's a very common phenomenon. I can tell you that if you've had an angiogram done, you're ahead of the game because they can see any small aneurysms that might be there. Even some of the MRAs wouldn't show it, but the angiogram will. So if you've had an angiogram, you're already ahead of the game for, having surveillance done and being monitored very closely for any type of secondary event that could occur. Pain is very common after aneurysm ruptures, especially in subarachnoid hemorrhages. Pain can occur in the head, the neck, and believe it or not, even in the lower back. When you suffer a subarachnoid hemorrhage and blood fills that subarachnoid space, like I showed you on the CAT scan and early on the presentation, the blood has to reabsorb, and the only place it knows where to go is into the brain and down the neck and down the back. And that's how it gets reabsorbed. And once it hits the lower back, it's usually, almost like coming out of your system, and it will dissolve and it will go away over time. So a lot of these symptoms that you experience are what we call self-limiting, where they will go away over time. And every patient is different when it comes to recovery. There is no magic day. There is no magic number. There is no magic year that some of these, symptoms are going to go away. But we do know that many of them do resolve over time and get better. Vision loss can occur depending on the location of the aneurysm. Some type of vision loss aneurysms could be something called a PCOM or an ophthalmic artery, and those type of artery aneurysms that rupture can cause vision loss. And some of them can leave residual deficits, and some of them can improve over time. And that usually takes longer time to recover than some of these other complaints. Lack of smell or taste can happen after craniotomy as well. very common, and they do tend to dissipate. And seizures occur due to some type of irritation that occurs during, during the lining of the brain from the cell injury. Seizures can occur, even later on after the craniotomy is done, or even after an endovascular embolization is over. So seizures get monitored while you're in the hospital. And, if you have a seizure at home, it's something that you should, definitely call 911 for if you've had an aneurysm in the past. And weakness is common too. When you rupture an aneurysm, it's a stroke-like phenomenon, and you get weakness on one side. So weakness too is a very major symptom after a brain rupture, and many things can be done for weakness, as we'll go over as we move. Okay, so this is an incision. This is a right-sided frontal parietal craniotomy incision. So this is an individual who had a surgical procedure to clip the brain aneurysm, and this is what the incision looks like. Some of them are smaller, some of them are a little bigger, and it depends on the location where the incision is going to be. So what do you do when you come home now and you have this incision? Because you will most likely go home with an incision that has staples and sutures sometimes. Sometimes you'll need a little drain that will come off of the scalp as well, and you'll have little staples or sutures where the drain was. And the drain really is a plastic little tube that comes out from the skull, and it drains the excess fluid from the subarachnoid hemorrhage. Okay, that is monitored in the hospital. You would most likely not go home with that. But the incision line is something that you're going to go home with. You're going to watch for signs of infection, and you need to know how to take care of it. Definitely, when you come home, the first thing you need to do really is to call your surgeon and to schedule an appointment with them. They usually will see you, after the hospital within 1 to 2 weeks. So it's very important to call your doctor to get the appointment. When you come home, the most important thing to do with this incision is to keep it clean and dry. Many patients wear bandanas, hats, and that's fine. I do encourage patients to also let air expose to the incision. Air can heal the incision a little better, so I wouldn't wear something on it 24 hours a day. But if you want to go out and you have company over and you want to cover it, that's absolutely fine. This incision is absolutely perfect. It is free from swelling, it's free from drainage, it's free from redness. Those are the major signs you want to look for if something is getting infected or something doesn't look right. The incision is also closed by the staples. So if the incision starts to open, that's a red flag. That's something that you really have to call your doctor for. Okay, as you can see on this young lady's face, her eye is swollen. Her face is not the same on each side, as you could see. The one side is very puffy, a little red here. Even on the side where the incision is, on the side of her face, is extremely swollen compared to the other side. And sometimes your eye will totally close after a craniotomy. These are normal findings after a craniotomy. And these symptoms do tend to improve even after a few days. After 24 hours, you even may see some improvement of the swelling. It's very common after a craniotomy, but like I was saying, the major things really to look for when you're home is the opening and the drainage and the swelling. Fever is another big sign. Yellow, fluid, anything really that's concerning, I would definitely call your surgeon. Even ear pain and jaw pain and trouble chewing can happen after craniotomy, and over time, those symptoms really do dissipate. You have to give yourself some time. You just had a major operation. Okay, I bring this photo in because this is what it looks like when you're in the interventional radiology suite and you're having an endovascular embolization done. And this is the groin, and this is what the catheter looks like going into the groin, and that is how they access to get into the vessels to do the stent and coil. That's exactly what it looks like. And once they're done, the procedure can take a few hours. Once they're done, they take that catheter out. They compress the groin with their hand to prevent bleeding. And then they put, sometimes, even in Europe and internationally, they use these little protein plugs called collagen to seal off the opening in the groin to prevent bleeding. And they will inject a little protein plug, perclose they're called, and they will seal off that area. And that, after they put that on, they put a dressing on. That's right there. It's called a safeguard dressing. And it has a little bubble on the end of it. It's a balloon. So once they compress the femoral artery in the groin area, they put a dressing on, a 4x4 gauze on there, and then they put this little dressing on it. And that bubble acts like a little pressure dressing. And they usually leave that on for quite some time until, things are quiet, and then they'll take it off and they look at your lab work and they can remove it. And once that's removed, you can move your leg. So the safeguard is put on just really to compress everything. Okay? Even though you do not come home with a major incision on your brain from the brain aneurysm treatment, if you have an endovascular repair, you do have pain in your groin site after you get home. You have a potential to have some bleeding there, which you need to call your doctor about. You definitely have a potential for bruising, hematomas, they call them. Ecchymosis is a bruise. And you might even have a little trouble walking from that site. So many patients feel like they were punched, in the groin once they had the procedure, and it can take some time for those symptoms to go away. But usually it's a lot quicker, a discomfort, as opposed to the open skull craniotomy. If you're on Plavix and aspirin, the bleeding can be a little more, prevalent. Any concern, you should not be bleeding from the groin when you go home. You're going to call your doctor. You may experience bruising, and you may feel a little bubble in that groin, a little marble-like feeling, and that's totally normal. That bubble is that protein plug that they inject there, and that bubble can sometimes take a few weeks to go away. It completely dissolves in the system. If the bubble gets red, if it starts oozing, if it hurts, and a different hurt from when you were in the hospital, that's something you're going to call the neurointerventionalist about, or your neurosurgeon. You have to remember that you're still recovering, and even though you don't have a very big incision on your skull, you had a brain procedure that requires some recovery. Okay, recovery times really do vary with every patient, and just know that you just survived brain surgery. Whether you had endovascular therapy or you had a craniotomy, you really are a super person for surviving that and coming home. Some patients do not survive brain ruptures. As you will see on the Brain Aneurysm Foundation, 40% of patients that suffer from brain aneurysm ruptures do not survive. So people that recover and go home, should be really feeling wonderful that they survived this brain aneurysm rupture and that you were given a second chance in life. Recovery time varies even with craniotomy patients. You can take 5 craniotomy patients and they will have different recovery periods. And you can take 7 endovascular embolization patients and they will have all different recovery phases. And anything goes. Everybody can experience those symptoms, those 10 classic symptoms that we discussed with memory and headache and back pain. All that can be very, very self-limiting. Some patients experience it for weeks. Some patients experiences it for months, and some of them even for years. Some patients, unfortunately, are left with disabling, neurological deficits, weakness, and vision loss. And, there are therapies and help out there, but some people, unfortunately, are left with some devastating effects. There are physical and psychological effects that occur with these ruptures. You have to accept the new you. Rehab is definitely one of the best options. Before you go home, the medical facility will really determine what type of therapies are best for you. So you may need physical therapy if you're weak. You may need occupational therapy if you have coordination issues. And you also may need speech therapy to speak better or to help find the words that you can't discover. There are many, many rehab options out there. Cognitive retraining is very, very common. Many people have trouble with their memory and trouble with thinking and comprehending. And I'm actually going to give you some tips as one of the last slides of how to really fix your cognitive rehab therapies. And support groups are wonderful. We have, as I was saying, one of the largest aneurysm centers here on Long Island. And we do a support group every month, the second Tuesday. It is not live. Unfortunately, it's not live where you can log on with a video, but it definitely is here available in the hospital, North Shore Hospital. It's a wonderful place for patients to come and grow and experience the same symptoms that another person is experiencing and realize that, you're not alone and that these symptoms are real. What you're feeling is real. These symptoms are not, you must be having so much anxiety. That is not true. These symptoms are real, real symptoms. And the Brain Aneurysm Center really focuses on getting support for everybody out there as well. So surfing their website is really very beneficial for anybody that has suffered a brain aneurysm rupture. Rehabilitation, believe it or not, 45% of people go directly home. The rest go to a rehab center, and it may be long-term, and it may be a nursing home, but, the majority of people do go home, 50% almost. Like I was saying before, follow up with your doctor is the number one thing when you want to do when you get home. It's very, very important. Everybody has specific discharge instructions depending on, what type of aneurysm you had and what type of treatment you had. So you need to really directly contact your doctor. Increasing your activity is very, very important. You need to talk to your doctor about what activities you can do. But I will tell you globally, if you've had a brain aneurysm rupture, you really want to avoid lifting and straining. So it's very important, not to lift anything until you see a doctor and get clearance from them. Avoid straining, avoid sliding and pushing. Laundry should be a no-no, and vacuuming should definitely be avoided. Believe it or not, pushing the vacuum is extremely exertional. Anything that increases the pressure in your head, which is the things I'm discussing, like pushing and straining, can be something of concern once you get discharged at home. So I would avoid anything that you're concerned about. If you do need to bend and lift something, bending at your knees is one of the best things you can do for yourself. Bend at your knees, keep your head up, and bend at your knees, almost like you're doing a squat. And that really is very helpful for patients that have come home from brain, intervention. Rehab centers really focus on improving functional ability and strength. Like I was saying before, they have the physical therapy, the occupational therapy, the speech therapy, cognitive therapy at your fingertips at these rehab centers. You're there 24/7. Some rehab centers are more aggressive than others. And unfortunately, we are limited by our insurance in the United States here. They do regulate some of the therapies that we get, and they can be limiting. So, my experiences, I tell patients all the time to go to rehab and get the exercises and do them at home. Once you get home, if you're limited in the ability to stay in the rehab center, it's very important. Even if you're home and you're getting physical therapy, it's very important, to bring that stuff back to your house, because the more you do it, the better you're going to be, and the better you're going to recover, and the more you're going to improve, and the quicker, which is really everybody's goal. The goal here is to have patients survive and give them a better quality of life and get them back to where they were, if it's all possible. If you're in rehab, usually you're there for 2 weeks. Sometimes patients are there a little longer. It depends on the disability. And, it's really take advantage of whatever have completed. Repairing your injury. The biggest thing is you want to really be happy. You want to think positively, okay? You want to not think about a second occurrence of the aneurysm, because if you dote on that, you will only think of that. You have to think outside of the box, that you've had all these images done and you're ahead of anybody out there that doesn't know they have an aneurysm. All of you know you have an aneurysm, or you had a rupture, you know the signs, you got to start thinking positive. Be healthy. You want to sleep well. You want to eat well. You want to start thinking about a little more healthy appetite, and that will all bring you to the next level to better recovery. Okay? It's very possible to return back to work, return back to intimacy. You just need to talk to your doctor about those things, but believe me, we've seen many, many miracles here happen from brain aneurysm ruptures. Counseling is very important. There are therapies all over. If you are not near a brain aneurysm center, there really is a lot of counseling that you can get in the community. You can go to, any type of library and get some, counseling there, or go to psych therapy, neurocognitive therapy. There are many things you can do to seek some counseling. Stress management, very, very, very important. Find a hobby that really makes you happy. Painting, crafting. There's so many things out there. Scrapbooking today. Go get a massage, get a pedicure, anything that makes you really just de-stress. Avoid smoking. And also try to do a little exercise if you're allowed to. You need to ask your doctor. Physical exercise, they actually know, can decrease, anxiety and stress. It actually improves the endomorphins in your body, and it really helps you get better and heal quicker and feel good. So exercise is a wonderful thing. If you are disabled, there are other options you can do, like yoga, and there are even wheelchair-bound physical exercises that you could do. You can buy videos today. You can go online on YouTube. The resources are endless today. If you can't get out of the house and you are wheelchair-bound, there are many social things you can do to get you more active. They do have wheelchair Pilates, like where they use the Pilates ball. It's pretty exciting to use if you are wheelchair bound. So I would really encourage you to try something like that, something different, something to help lift your spirits. And social activity, I would check out some of your library resources, some of your church resources, if you're religious, some of your temples. They have social activities for, anybody that really wants to get out. Family time, I would encourage. Many patients have told me that when they suffer a brain rupture, that they become more close with many of their family members, and they don't sweat the small stuff anymore. And that's something that I think all of us, even without experiencing an illness, should really think about on a daily basis. If you just took 5 minutes out of your day to just think about what you're happy about and what you're glad about that day, it makes a world of difference. It really changes your whole mindset, and it's very, very important. Some other social activities that you could do really are chat lines and support groups, even online. You can write in today. They have just so many opportunity available. You can go on Google and find any type of social internet that can really help you recover. Talking to survivors is also another very uplifting experience. Neuro fatigue. I think neuro fatigue is probably one of the most biggest challenges for all of you today. It really has to do with the way the nerve cells are damaged, why you experience neuro fatigue. And yes, neuro fatigue is very common in patients that have undergone endovascular embolization. So even though you haven't had a major surgery, many of my endovascular patients complain of neuro fatigue. It does get better over time, and there are ways to help break the cycle. You have to think of your brain really as a battery in a cell phone. And many of you, I think, can relate when your battery is on 1% and you forget to plug it in. and then you go to plug it in, it takes forever for that battery to regenerate and to turn back on. And you have to think about that as your brain. Your brain really needs time to reboot. It needs time to recharge. It needs time to energize. And letting it deplete is going to cause more neural fatigue. So, that's a take-home message that I really hope everybody just can take out of this presentation tonight, is that you need to take care of your fatigue because it will overcome and take over you. And some ways to do that is to start delegating tasks, have other people do things you used to do on a daily basis, take frequent breaks. I encourage all of my patients, listen to your body, rest, take naps, and take those breaks. Sitting on the couch is okay in the early phases of recovery, because after, the early phases of recovery, neural fatigue does improve. It does get better. You need to plan ahead. If you're having a big outing that day, a wedding, an event, you need to plan ahead. I'm going to rest right before the event so that I can really enjoy my day and get everything fulfilled that you want to do during that busy day. So you start to have to really think about other ways of treating fatigue. It is a true symptom, and nobody really can sit there and say, I know how you feel, because they're not you, but neural fatigue is real, okay? You cannot use all your cognitive reserve in one day. You have to preserve it once you had an injury to the brain. And it's very, very important to do all of these things in order to restore the brain power. We live in such a fast-paced world today, and everybody wants everything right away. But when you had an injury to the brain, you have to remember it's a closed vault, and it takes time to heal. And sometimes the only way the brain can tell you, I need rest, is by getting tired. So you really just need to take a step back and say, I had an injury to my brain, and I'm going to take a break. And there's nothing wrong with that, and it really does help overcome some of that neural fatigue. There are medications out for neural fatigue, which, we do not recommend, but there are medications if it's been years that you are suffering from neural fatigue. I would talk to your doctor about the symptom, but these tasks and these, these treatments that I'm explaining really can help neural fatigue more than some of the medications out there. Patients that have memory issues and cognitive issues, these are some great websites that I really encourage all my patients to do once they come home. They help coordination, they help comprehension, and they help thought processes. So they're very, very, instrumental in getting better. They reboot your brain cells. You can find them on any computer, and these are the websites. I really, I think they're just a great approach to really help patients with their memory. They help with thinking if you don't have the resources to go to any rehab. And lastly, I want to talk about books. I'm a big fan of reading books. I actually read Humdinger, and it was extremely enlightening, and it really helps patients connect to having suffered a brain rupture. Many of these books go through the phases of what has happened to patients once they've suffered from a brain aneurysm. I really encourage patients to read. They boost morale. They're enlightening, and they're really they're tear-jerking. They're everything that you could imagine, and they really do help recover. They help patients connect with what they're feeling as well, because sometimes it's very hard to connect to, a human being when they're experiencing this anxiety. And these books really do help patients recover a lot better. And I encourage them. You can even, Google any other book. These are just, odd things that I picked up as I went along in my career. Our Brain Aneurysm Center has a brain aneurysm walk that, is in collaboration with the Brain Aneurysm Foundation once a year. We do this in September at Jones Beach on Long Island. So if you're in the area, we would love to see you. It's a special year. It's our 10th annual walk. And we also have support groups once a month. I would like to take the time right now just to thank the Brain Aneurysm Foundation tonight for having me. They've made this night possible. And they also carry out a mission that our hospital is in alignment with, where we raise awareness and provide resources for our patients who have suffered brain aneurysm.